what is a joint? Well, joints are created by two bones coming together, typically long bones. Okay. But you can form joints in between vertebra. Okay, intervertebral discs are the shock absorbers, and then those facet surfaces provide joints in your vertebra. So arthro, anything that has arthro associated with it, arthrology, arthrogram, arthroscopy, that has to do of or relating to a joint. So joints or articulations can be either bone to bone, they can be bone to cartilage, which most of them are, or the third and most unique form is your teeth in your bony sockets. So those are joints, but they have a special name and they're only found in the mouth. So we'll go over that. So joints are designed to resist crushing, tearing, and other forces, but because joints is where movement is created, that sets joints up for an increased susceptibility to wear and tear and decline. Okay? All right, so how do we classify joints? There's two ways. We can classify them based on the amount of movement that they provide, okay, or by their structure, by their anatomical structure, okay? So let's talk about movement first, okay? And this is, again, terminology. Arthroses means of or pertaining to a joint, okay? So we've got synarthroses, amphiarthroses, and diarthroses, okay? A synarthroses essentially means no movement, okay? So no movement is provided at that joint, okay? A diarthroses is freely movable. Okay. So what do you think amphiarthroses means?
Partial.
Yeah, kind of like half and half. So you could say slightly movable or somewhat movable. Okay. So every joint in the body can be classified in one of these three categories based on the amount of motion that's provided at that joint. A majority of our joints in the body are freely movable, okay, which is a good thing. Okay. Now, if we're going to base the classification on structure, okay, we have to utilize the material that binds the bones together. So what are we talking about? Are we talking about connective tissue? Are we talking about cartilaginous tissue? What are we talking about? The presence or absence of a joint cavity, and we'll talk about that. So those two criteria are used to structurally classify joints. Does it have a joint cavity, and what material brings that joint into existence? Okay? So there are three structural classifications that you need to know. The first one is fibrous. So if we're classifying a joint and calling it fibrous, what kind of material do you think binds it together? Yeah, like fibrous connective tissue, right? Yeah. Okay. What about cartilaginous? What kind of material? Cartilage. Yeah. And synovial joints are joints that have a joint cavity. Every synovial joint has a joint cavity. Okay. Okay. So let's go through each classification, okay, structurally, and give some examples. So in fibrous joints, we've got fibrous or dense regular connective tissue that's going to connect the two surfaces. There's no synovial cavity, okay, there's no joint cavity. Most of them, because of that then, have no movement, so they're synarthrotic. Some of them are amphi, but a majority of them we're considering synarthrotic. Okay, majority of them are synarthrotic. And we've looked at one in lab, suture. A suture is structurally considered a fibrous joint, okay? Do we typically have movement at sutures? No. Sutures are designed to just connect the flat bones of the skull together, right? Sagittal suture, squamosal suture, lambdoidal suture, frontal suture, okay? Syndesmosis is another example, and I'll give you some examples of that. and then gomphoses. Gomphoses is the one we're gonna find in the mouth. Okay, so first, sutures. Okay, there's a minimal amount of tissue, there's no joint cavity. It's basically kind of like one puzzle piece meeting another puzzle piece and interlocking to provide stability. Okay? But there's a little bit of tissue there to allow for growth. Okay, so we've already seen the fontanelles in the fetal skull, so we understand the purpose of having cartilaginous tissue kind of interspersed in between osseous connective tissue for the purpose of growth. Okay, so as far as the syndesmoses is concerned, you've got bones connected with a small amount of collagen fibers, collagen protein fibers, okay? And these are longer than sutures, so sutures are like short structures that connect the flat bones of the skull together. Syndesmoses have a little bit more length to them based on the bones that they're connecting to. So the two examples that I want you to know for a syndesmoses is the tibiofibular joint, okay? This is distal, so this is at the bottom. So this is where we have the medial malleolus, and what's on the fibula? The lateral malleolus, okay? So connecting lateral malleolus to the lateral aspect of the tibia is a ligament, and it's called the tibiofibular joint. Okay, there's no movement there. It's providing structural stability between the two bones, and structurally it's considered a syndesmoses. Okay, but motion-wise, functionally, it's considered synarthrotic because there's no movement. Okay, so for each joint that we're listing, make sure you know the structural classification and the functional classification. Okay, the other example of a syndesmoses is the interosseous membrane in between the radius and the ulna. Okay, again, collagen fibers running in a diagonal. This provides slight movement, amphiarthrotic, okay? So this is something that I can mobilize when, for example, somebody comes in with a broken arm and they've just gotten out of their cast. They're just gotten out of their cast, they're really stiff, they're really tight, hard to move. Okay, they can't rotate their palm, they can't do much. So I can get in between the radius and the ulna and I can mobilize that structure slightly, just to provide a little bit more motion, a little bit more movement. And most patients love it. They say, oh God, it feels so good, I can actually move. Because again, if you've been in a cast for 6 to 8 weeks, you haven't moved it at all and it drives you nuts. So you get out of the cast and it's like, I want to move it. So I can mobilize that a little bit because that joint has a slight amount of movement. Okay. Okay, so the gomphoses, the last example, is your tooth in a bony socket. Okay, so the periodontal ligament is what's involved in connecting your tooth to the bony socket. Okay, and we're talking about adult teeth here. We're not talking about baby teeth where you lose them and then get a new set. So these are adult teeth. Okay, and with adult teeth, should there be movement in between the teeth and the socket? No, there shouldn't be any movement. If there's movement, there's a problem. So functionally, they're going to be synarthrotic. So the only place you're going to find a gomphoses in the body is teeth in their bony sockets. Right? Okay. So that finishes off the structural classification of fibrous joints. Okay. So now we're moving on to cartilaginous joints, and cartilaginous joints have cartilage as their tissue that binds them together. Cartilaginous joints still don't have a joint cavity, okay? So they can be no movement or slight movement, okay? And we have two different kinds, okay? So we've already talked about the term syndesmoses and synarthrotic. Now we're introducing synchondroses. You got chondro in there for cartilage, and symphyses. Okay, we've already heard of symphyses in lab. So again, a lot of these terms sound similar. That's why you guys have two handouts to play with. Okay, so the synchondrosis, hyaline cartilage, example, epiphyseal plates. Okay, we know this is, what kind of cartilage tissue? Hyaline, the most abundant, right? Mm-hmm. So, growth plates, should they move? No, you don't want any movement. There can be growth, there can be cellular growth, but that's not moving the plate, okay? The plate should not move. Okay, so that's synarthrotic for sure. And then you've got basically the first joint between the manubrium and the first rib. Okay, that's another example. And that again is immovable, so that's synarthrotic. Okay, so those two examples have hyaline cartilage attached to them, making them a synchondroses. Okay. Okay, symphysis. What's a symphysis that we identified in lab? Pubic symphysis, right. And pubic symphysis is what kind of tissue again? Hyaline cartilage fibrocartilage connective tissue. That's right, fibrocartilage. Okay, fibrocartilage is the main element. Okay. In addition to the pubic symphysis, another example of a symphysis in the body is what we looked at in between the bodies of the vertebra, the intervertebral discs. So you get slight movement. Again, at the pubic symphysis, if you, for example, try to kick something really heavy with the inside of your foot and you feel a click in the front of your pelvis, that's you adjusting your symphysis pubis. And you have slight movement, so it's amphiarthrotic. Okay? Same thing with the intervertebral discs. You can get a little bit of movement in between the vertebra because the discs are shock absorbers. Okay, so it provides a little bit of movement, which is nice. Okay, so those two examples are symphysis. Okay, so that rounds out the structural classification that's cartilaginous. So now the final structural classification is synovial. And synovial joints are the most abundant in the body. Those are the joints that I work with most in the clinic. And those are all diarthrotic. They all are freely movable. And they all have a joint cavity. Okay? So most synovial joints have just two bones coming together to form the joint. There are some places in the body, two coming together is simple, compound is more than two. So essentially in the elbow and in the knee joint, you've got more than two bones coming together, which makes it compound. So in the elbow, all right, in the elbow you have what? You have the humerus, and then in the forearm you have what? The radius and the ulna. So that's three bones, that makes it compound. In the knee, what do you have? You have the femur, and then you have what? Tibia and the fibula. So that makes those two joints considered compound because they have three bones associated with them. So essentially, a quick way to think about it is any joint in the body that can swell up is a synovial joint because it's got synovial fluid flowing inside of it, and we'll talk more about that. Okay, so at the ends of long bones, we've already looked at this, we've already talked about this. We have hyaline cartilage, so it's blue in the picture. Okay, so that's going to provide a slick surface at the end of each of the long bones that can slide along each other and provide some sort of movement. Okay. The cartilage also protects the ends of the long bones and absorbs some compression, so it's got a little bit of compressive ability to it. Okay. So the cavity in between those two articular surfaces of cartilage is called the synovial cavity or the joint cavity. And that cavity houses fluid. And I said in the beginning, I think the first day or two of class, any fluid in the body that we talk about is a derivative of what in your body?
Serous.
We're talking synovial fluid. Where does that come from?
Ground substance.
Okay, that's an example of fluid. Provides the multitude of different fluids found in the body. It's blood. Okay. So synovial fluid is going to be a direct derivative of your bloodstream. Okay, so because there's a synovial joint, there's going to be a capsule that we call an articular capsule that surrounds the joint. And that capsule is going to be connective tissue. Okay, fibrous, dense, irregular connective tissue. Again, irregular because it allows for changes in movement. okay, because they're diarthrotic joints, lots of movement, so we gotta have a little flexibility there. And that connective tissue is gonna be continuous with the periosteum of bone, so the periosteum layer of the bone is gonna give it an attachment site on either end, okay? And within the joint cavity, on the next page is actually better, we have what's called a synovial membrane. Okay, so on the previous slide, the synovial membrane, okay, is the deepest layer of the articular capsule. So I like this picture because it breaks it down. The articular capsule includes superficially the fibrous capsule, which is made of the dense irregular connective tissue. And then deep to that, kind of greenish in this picture, is a synovial membrane. And the synovial membrane surrounds the joint cavity and covers all surfaces except for the hyaline cartilage. And that synovial membrane is going to make synovial fluid for that joint. Okay. Okay. So, as far as synovial fluid goes, it's not pure water, okay? It's similar to raw egg white, so it's got a little bit of protein in it because it's, again, a derivative of your bloodstream, okay? So the fluid is designed to reduce friction, absorb compression, okay? The fluid can also be squeezed out of the synovial membranes as the hyaline cartilages come in contact with each other. And that fluid provides like a slippery surface for the cartilages to kind of articulate with each other without creating heat or friction. Okay? So you're constantly making synovial fluid and then you're constantly resorbing it because it's coming from the bloodstream. So typically around most of your synovial joints, you have a good blood supply because that blood supply is going to be providing the synovial fluid. Okay? So capillary beds, we haven't talked about blood vessels yet, but again, capillary beds are the smallest version of blood vessels where exchange happens, so where leakiness can occur. And this is, out of these capillary beds is where the synovial fluid is going to leak out of and be created within these synovial joints. Anastomoses just basically means that you've got overlapping blood vessels, so that if some blood vessels aren't functioning properly, the other ones can pick up the slack, okay? And that's important for synovial joints because they're gonna need a blood supply constantly in order to provide the joint constant synovial fluid, which is being made and resorbed by the body. And this is to keep the joint healthy, to keep the articular cartilage healthy and the joint itself healthy, okay, for a majority of your life, right? Okay. Synovial joints also have nerves, so if you sprain your ankle, okay, sprain your knee, whatever, you feel it, it hurts, okay, and usually it swells up, right, because you get excessive synovial fluid in the area, triggering an inflammatory response. So then you come to see somebody like me as a physical therapist to try and reduce the inflammation, do soft tissue mobilization to kind of pump that fluid and push your body to resorb it back, so that you can get more motion back at the joint. Because when a joint's really swollen, what happens to motion?
It's limited.
It goes down, right? And that's your body's protective mechanism. Ooh, there's an injury, we'll puff it up, and then we'll create, you know, a problem for you moving it because we want to protect it because there's something wrong. And then once that swelling goes away, once the pain goes down, give it some time to heal, then over time, sprains resolve, okay, and you go back to your prior level of function. Nerves can also monitor how much the capsule of your joints are being stretched, okay? So, for example, your shoulder joint. If you're at the gym stretching your pec major, maybe you're like in a corner and you're doing a really nice corner stretch, like you can stretch up to a point, right? And then at that point where you're like, okay, this is a really good stretch, if you try to push it, what kind of feedback does your body give you?
Pain.
Pain, right? It gives you pain. So you go from stretch to like, ow, this isn't fun anymore. And it's your body telling you, hey, whoa, back off. You're going a little too crazy right now. Back it off. And it's, again, a warning sign. So it's good to have innervated joints, okay? Okay, so since synovial joints are the most abundant structural classification in the body, we can further subcategorize them, okay, based on movement, essentially, okay? And fortunately, we've looked at most of the bones already in lab, so hopefully a lot of this will make functional sense to you guys. Okay, so a plane joint is basically where you've got two flat surfaces of a bone coming together, okay? And it provides gliding, okay? So it's pretty much only gliding between the surfaces of the two bones, okay? So gliding is in one plane of motion. It doesn't involve any kind of rotation, okay? It's just gliding, okay? So your intertarsal and your intercarpal joints, okay, so bones of the foot between the talus and the calcaneus, okay, between the scaphoid and the lunate, okay, those are gliding. Those are planar joints. They just glide in between each other, okay? Your vertebra, okay, your vertebra glide. Those facets glide. One surface, planar movement, gliding motion, okay? So again, if someone comes in to see me, say they fractured their ankle and they had to have hardware put in, and they were casted for 6 to 8 weeks, they come to see me, they just got the cast out, they're still on crutches. I come and look at their foot, it's still huge, it's still swollen, okay? But they haven't moved it because they've been casted for God knows how long. And they're getting antsy. They want to move around. They're tired of being cooped up in the house and whatnot. So I start doing soft tissue work on the fluid and the inflammation and the synovium. But then I also will take those carpal joints. I'll take like the navicular and the cuboid and the talus bone, and I'll glide them along each other. Again, patients are like, oh my God, that feels so good. Because I feel like you're moving something that hasn't been moved in a long time. And it just feels really good. It's not something that I can do myself. So there you go, gliding movements. Okay, so hinge joints. Hinge joints, I think of a door hinge. Door can open and it can close. And that's pretty much the only movement that it provides, right? So we typically call that uniaxial. Uniaxial, so it's one axis of motion. The elbow is a great example. You can either bend it or you can straighten it. There's no amount of rotation that you can do in the elbow. It doesn't happen. It's either bending or straightening, okay? The ankle, you can either bring your toes up towards your head or you can point them away from you. That's it. There is an element of rotation to it, we'll get there, but right now, we're just thinking basic functional movements, okay? The knee, you can bend it, you can straighten it. You can't rotate the knee. You can't just, oh, I'm gonna rotate. No, it doesn't work that way. You can't rotate the knee, okay? Your phalanges, your interphalange joints, right? You can bend your fingers and you can straighten them. That's it. You can't like rotate, you can't do anything else. So those are hinge joints, okay? So those are uniaxial. Uniaxial. Okay. So pivot joints depends on where you are in the body. There's two great examples of pivot joints in the body, of which structures we've already looked at in lab, okay? So a pivot joint is going to provide some sort of rotational component, pivoting, okay? The first great example is the articulation between C1 and C2, right? Because C2 has that unique feature called the dens, and the dens sits up against that anterior tubercle of C1. Well, there's a ligament that keeps the dens against that anterior tubercle. It's called the transverse ligament. And so when you're rotating your head to say no, that's basically pivoting happening right in this interface. Okay, so those are considered pivot joints. Those are rotational joints. Okay. Another place in the body is between the head of the radius. And what part of the ulna does that articulate with? What structure?
Radial notch.
The radial notch, right? So that allows for the head of the radius to rotate, and it allows you to do palm up versus palm down. Okay, it's happening right at that joint. Okay, so this is a pivot joint. Rotational movement only. Okay, so a condyloid joint is kind of like the rounded end of a bone with a depressed end of another bone, okay? Because we know that a condyle is a rounded end of the bone, right? Medial condyle, lateral condyle of the femur, things like that, humerus, all that stuff. Okay, so when you have this type of scenario, okay, it's going to give you a biaxial type of movement, okay? And the joints that we're specifically talking about here are the metacarpal phalangeal joints. I know it's a mouthful, but it's basically just telling you exactly where in the hand it is. It's in between the metacarpal and your proximal phalange, okay? It's these joints right here. What do we call these joints? Layman terms.
Knuckles.
Knuckles. These are your knuckles. So your metacarpal phalangeal joints are your knuckles, all right? So your knuckles, you can do two motions, okay? Two different directional movements. You can flex them and extend them, okay? So you can flex and extend, but you can also abduct and adduct at those joints. Two different types of motion, biaxial, okay? And we'll talk more about these terms, abduction and adduction in a bit, flexion and extension, okay? The radiocarpal joint is the distal end of your radius articulating with the carpal bones, okay? The distal end of your ulna doesn't really articulate with the carpal bones. It's too small. You guys have already identified where the styloid process is. It's very small. The radial styloid process is more meaty, it's bigger, it's a big bony prominence that you can palpate, okay? So the articulation between that and your carpal bones, again, can provide two kinds of movement. It can provide flexion and extension, or it can provide adduction or abduction. And that's all coming from your radiocarpal joints because they're condyloid in shape. Okay. Okay, so that's biaxial. Okay, saddle joints. Saddle joints are awesome because there's only one in the body, and it's your thumb. It's your first carpo-metacarpal joint. So it's the articulation between your metacarpal joint, okay, your first metacarpal joint, and can anyone tell me what carpal bone? Potentially? What's the first carpal bone in the mnemonic?
Scaphoid.
The scaphoid. Actually, no, it's not the scaphoid. I lied. Trapezium, sorry. It's the very last bone, not the first bone. So it's trapezium. Trapezium and your first metacarpal, CMC joint. And it's classified as a saddle because of the shape of the bone. So the shape of the trapezium is like C-shaped, and then the end of that first metacarpal bone is like a saddle that it lives in. And what that does is that allows your thumb, as compared to all the rest of your fingers, your thumb can do the motion of opposition, where it can touch the other tips of your fingers. And that's for dexterity. That's for motion and functional use of the hand. Again, we'll talk about those terms again in a minute when we talk about actions. So saddle joint, first metacarpal and trapezium bone. Okay. Okay, so the one that you guys are probably most familiar with is a ball and socket joint, because it's the ball end of one long bone articulating with the socket of, or depression of, another bone. The examples would be the shoulder and the hip. So, what are the articulating surfaces of the shoulder joint? What part of the humerus? The head, okay. And what part of the scapula?
The
Glenoid cavity or the glenoid fossa. So that's the socket and the head is the ball. So what about the hip? What part of the femur? The head. And then what about the os coxibone? The acetabulum, which is the depression, the socket, much deeper socket for the hip. So both of these guys, based on shape, ball and socket, huge amount of motion, okay? We call that multi-axial, okay? Lots of movement, man, 360 degrees of motion. You can just whip it around. But the exchange for having that much motion is, again, the tendency for wear and tear over time and or breakdown. Okay, questions about the classifications? Again, it's kind of a lot of terms, but okay, so if we're talking about actions, okay, flexion and extension, it's basically talking about the angles between the two bones that are articulating together, okay? So in the top picture, if you look down towards the floor, you're flexing your neck. If you look up towards the ceiling, you're extending your neck, okay? If you go from looking at the floor back to original position, that's extension. If you're looking up at the ceiling, that's considered hyperextension. So you can go beyond, okay, what's considered full motion. So if you're flexing the back, you're bending forward. If you're extending the back, you're coming back to original position. And then if you're hyperextending, you're going beyond that. Okay, so flexion and extension are typically in the sagittal plane. Okay, same thing with the elbow, right? If you flex the elbow, the angle between your forearm and your arm gets smaller. Okay, if you extend it, the angle gets larger. Same thing with the knee. I think I have, yeah. So if you flex the knee, bring your heel to your butt, this angle gets smaller. If you extend it and straighten your knee back out again, that angle gets larger. So that's just the definition of flexion and extension. Okay. Okay. What else did I want to say? Now we already talked about regional terms in the body, like gluteal, brachial, things like that. When you're talking about the action, okay, of a muscle, which we'll get to in the next unit of study, but when we're talking about movement, okay, if we're talking about, for example, flexion of the elbow, bending of the elbow, you can say, you can describe the motion at either the joint or what part of the body is moving, okay? So you can say, I'm flexing my elbow, or you can say, I'm flexing my forearm, because that's what you're doing, okay? So I could say, I'm extending my elbow, or I'm extending my forearm, because that's the part of the body that's moving, okay? Forearm is different than arm. Flexion of the arm is arm straight up in the air. That's flexion of the arm. Extension is back down to resting position. Okay, hyperextension is going even further back. Okay. Same thing applies in the leg, and we're going to repeat this in lab because there's an exercise for this. You have your thigh. Your thigh is thigh march. Okay. If you're flexing at the hip, you're flexing your thigh. Okay, so you can say hip flexion or thigh flexion. That's fine. If you're flexing your knee, so if you're bending your knee, you're doing knee flexion or you're doing leg flexion. Okay, it's not thigh flexion, it's leg flexion. It's the part of the body that's moving. Okay, so we'll practice that. Okay. So abduction and adduction. Again, this is where anatomical position comes in handy. So you guys all know what a jumping jack is, right? Am I that old? Okay, you guys know what a jumping jack. Okay, so I think of a jumping jack. When you do a jumping jack, this is abduction, abduction. When you go back to the starting position, it's adduction. Okay, we're talking about coronal plane movement. Okay, ooh, my left shoulder's tight, I gotta stretch. Okay, so the way I think of adduction is that you're adding it back to you. You're bringing it back to you. So adduction is bringing it back. Okay, you're adding it back. Abduction is away. Okay, doing your jumping jack. Okay, so abduction by definition is movement of a limb away from midline. So that's arm or leg. And then adduction is bringing it back towards midline, adding it back to you. Okay, so you can do the same thing with your fingers. You can abduct your fingers, or you can bring it back to you. Adduct your fingers. This is coronal plane movement, frontal plane movement. Okay. Okay. They say middle finger is midline because in your hand, it's kind of like, what's the reference point? For your body, it's just midline. So for your hand, your middle finger is the midline. You're bringing it back towards the middle, or you're going away from the middle. That's pretty much what middle finger means. Okay. Circumduction. So circum, going around, a roundabout. Okay. So if you're moving a limb or a finger so that it describes a cone, it's more of a limb, not so much a finger. But if you're moving a limb so that it does a cone-shaped movement, where in the body do you think you can do circumduction?
Your arm. Ball and
Okay, your arm. What specific joint?
ball and socket.
Ball and socket. What specific joint? Just layman's term. Shoulder. Right. So you can do circumduction at the shoulder. What other joint? Your hip. Yep. You can do circular motions at your hip. Yeah. So shoulder and hip are good examples of circumduction. And circumduction involves rotation. Okay. So it occurs at the hip and shoulder joints. Vertebral column is a little different. I mean, because vertebral column straight up and down, you can rotate to the right and you can rotate to the left. That's pretty much, you can't really do circular movements with your vertebra. That just doesn't happen. Okay. What else do I want to say about this? Okay, so medial rotation versus lateral rotation. Okay. Medial rotation is also called internal rotation. Okay. And that means you're rotating towards you. Okay. So rotation towards the body is considered medial rotation or internal rotation. Okay. Lateral rotation is also called external rotation. That's rotation away from you. Okay. So if I'm at the gym and I'm holding on to my little exercise. Okay. Supination and pronation, that's the motion that I was demonstrating with the head of the radius in that radial knot. So the way I like to think about it is you serve your soup in supination. So you serve your soup in supination, and pronation is palms down. Okay. So very common fracture in the elderly is when they fall on an outstretched arm. So you're tripping, you're falling backwards, and all of a sudden you reach back with your hand, boom, all that force gets transferred to the head of your radius, boom, fracture, okay? Fracture, casting, maybe some hardware. Dorsiflexion and plantar flexion, we're talking about the ankle when we use these terms. And the way I like to think of it is dorsiflexion is the ankle is moving towards the dorsum or top side of the foot. Ankle's moving towards the top side of the foot. Plantar flexion, ankle is moving towards the plantar aspect of the foot. Okay? So if you came into the clinic and I asked you, I wanted to do a strength test on your legs, and I asked you to walk on your heels, what motion is that at the ankle?
Dorsiflexion.
That's dorsiflexion. And then if I had you walk on your toes, that's plantar flexion, right? Okay. Do that all the time. Okay, so here's where the ankle gives a little bit of rotational component, okay, and that's called inversion and eversion. Inversion is rotating the ankle towards midline. Eversion is the opposite. you have more inversion range of motion than you do eversion, naturally. Eversion, you get about 10 degrees, you don't have to memorize that. Inversion, you get about 20 to 30. And anyone that's spraying their ankle, what typical mechanism is it? Are you spraining it into inversion or eversion? Inversion, right? Because you have more motion that way, you usually roll on the outside of your ankle, and that's where the lateral aspect of your ankle gets all swollen. Specifically around that lateral malleolus where you have a bunch of ligaments. Okay. Okay, protraction and retraction. So they're using the example here of the mandible. So if you protract the mandible, you're giving yourself an underbite. If you're retracting it, you're going back to neutral. If you're going beyond that, you're giving yourself an overbite, okay? But you can also do protraction and retraction at the shoulder, okay? So protraction, you can well, all of you that slouch, you're all of you are protracted. Everybody's protracted, okay? Pecs are super tight, everybody's slouched. That's just your typical posture, right? So if I come and I say, okay, I want you to stand up tall and squeeze your shoulder blades in your back pockets, okay, that's retraction. That's retraction of the scapula. It's probably the #1 exercise I give in my profession because everybody's like this. Everybody's slouched. It's like, stand tall, get your shoulders down and back. Beautiful, hold on to that. Harder than it looks, okay? So that's retraction of the scapula. And then lateral and medial excursion is just the ability for you to move your mandible away from midline, bring it back to neutral. Away from midline, bring it back to neutral. Okay. Okay. Elevation and depression. So again, they're using the mandible here. So if you elevate the mandible, you're closing your mouth. If you depress the mandible, you're opening your mouth. But you can also elevate and depress your shoulders, right? So if you're at the gym and you got free weights in your hand and you're elevating, you're bringing your shoulders towards your ears, right? If you're depressing, you're bringing it back to neutral or bringing it back to the starting position, okay? Okay. Opposition. Again, that special action that your first carpometacarpal joint provides you so that you can touch the tips of your fingers with your thumb. You can't really do that with your other fingers. You can touch the back side of your other fingers, but you can't go tip to tip. Just can't do it. You can only do that in your thumb. Okay. It's that saddle joint. Okay, so when we talk about joints, because they provide movement at the expense of injury, okay? The more motion that's provided at a joint, the more risk of injury, okay? And there are several different anatomical structures that provide some form of joint stability, okay? The first one is the articular surfaces, but those really don't play a role in joint stability. So the hyaline cartilage that lives on the head of the humerus and the glenoid cavity, that's not really going to provide a lot of joint stability, okay? Because the head of the humerus is so much larger than the glenoid cavity, you have a cartilaginous structure around it called the glenoid labrum. Has anyone had labral tear? Or know anyone that's had a labral tear? No? You guys are so healthy. Yeah, okay, good. So the labrum is it's almost like a cartilaginous suction cup that goes around the glenoid cavity. And what it does is it increases the surface area of the glenoid cavity. So the head has more surface contact, okay? But because of that, you can tear that labrum if there's an injury and the labrum can't sustain it, okay? Okay, ligaments. So ligaments attach bone to bone and they provide structural stability in the joints. We're going to look at ligaments of the knee today, on the knee joint. There's lots of ligaments in there, okay? Okay, it provides some stability, yes, but if a ligament's torn, there goes that stability. Okay, ligaments are not like rubber bands. They don't just spring back. Once it's torn, it's torn. And you can either fill in with scar tissue, or you'd have to have it surgically repaired or replaced. Right? Okay, and then the last is muscle tone. This is what keeps me in business. Okay, muscle tone. Because this is the most important factor in joint stability. Okay, everybody has some sort of weakness. Nobody is perfectly strong. Nobody. Okay, so like every single patient that comes in to see me has some sort of weakness somewhere. So if they're coming in with shoulder pain and instability or injury or surgical intervention, I'm going to assess the musculature of the shoulder joint and find the weakness. Where are they weak? Usually it's serratus anterior. We'll go over muscles next week. Okay, but muscle tone, if we can reestablish fantastic muscle balance, symptoms reduce. Okay, happiness goes up. Functional mobility improves, kind of thing. Okay, so muscle tone is number one, which is nice because you can affect that. You can strengthen that and build that or rebuild it. Okay, ligaments and articular surfaces, we don't have control over that. It's just kind of like, well, you get what you get, and if you hurt it, then we just have to kind of work with that. Okay. Okay, so just general characteristics about the joints that you're more familiar with. Okay, the glenohumeral joint, which is the shoulder joint. Okay, so it's diarthrotic, it's synovial. Okay, there's that glenoid labrum that I talked to you about. It's made of fibrocartilage, so it makes the glenoid cavity a little bit bigger, so the head of the humerus has more contact area. You've got ligaments around the shoulder. Okay, great. But again, we already know that doesn't provide the most stability. Okay. You've got a biceps brachii tendon, and when we next week talk about the biceps and you guys learn where the two heads of the biceps insert, it'll make more sense because the long head of your biceps, which is what you do when you do your bicep curls, right? The long head of the biceps attaches at the top, at the supraglenoid. What is that structure called? That you had to know in the scapula, supraglenoid tubercle. So that's where the long head of the biceps brachii attaches. So it attaches over and above the shoulder joint, okay? In addition to that, you've got the rotator cuff, which is 4 muscles. Again, we're gonna learn all this later. You don't have to memorize this right now. We're just talking about joints. But the rotator cuff, 4 muscles, front, back of the scapula, provide muscular stability to the shoulder. Okay? So, if one of these gets torn, you get a rotator cuff tear, or maybe a rotator cuff tendonitis. Guess who's gonna kick in? Okay? Biceps is gonna kick in. Long head's gonna be like, all right, I'll take over, I'll help out. But biceps brachii is only involved in doing this. Your rotator cuff is involved in rotation. Okay? So the biceps is going to keep trying to do what it's going to do to try and help you, but in doing that, it's going to get tired, and it's going to get pissed off. And I can tell you that I've never met somebody who's seen me for rotator cuff injury that does not have a pissed off long head of the biceps brachii, because that biceps has just been working so hard to try and help out, and it just can't. Because physiologically, it's not in the right position to provide the same motion that the rotator cuff does. So I get in there, I palpate, they hit the ceiling, and I'm like, okay, a little tendon is there. They're like, how do you know where to point, and how do you know where to poke and everything? I'm like, well, I kind of know my anatomy, right? So, okay, this is really just, it's just kind of emphasizing that labrum, really. That's all, just extending the surface area. Bursa, we'll come up on a slide that has bursitis on it as a pathology. Bursa are fluid-filled sacs, synovial fluid, that live underneath tendons. And they allow tendons a nice slick surface to contract. But bursa can get pissed off. Okay, and bursa can become inflamed. So just yet another part of the body that can get upset if it's not used properly. This is basically just comparing the deepness of the socket between the hip and the shoulder. So which socket is deeper?
Hip joint.
The hip joint, right? The acetabulum is much deeper than the glenoid cavity. So the hip joint is inherently going to be a more stable joint, right? You don't really hear about hip dislocations very often. If you do, it's traumatic. It's like a car accident or something forceful that popped out the hip. Shoulders, I mean, water polo players can sublux their shoulder and partially dislocate. Volleyball players, especially the lanky, girls in middle school and high school that are growing, they're undergoing puberty, so they're growing and their body's trying to accommodate and they're just overusing the arm and boom, they just get subluxations and dislocations, very common in the shoulder. Not so much in the hip. You don't really get hip dislocations, unless again, it's a trauma. This is showing a little bit of rotator cuff. Again, we'll do that next unit of study. And then ligaments, we're not identifying those specific ligaments in the hip, but the hip has quite large ligaments that again reinforce the joint, which makes it really stable. I mean, the head of that femur is in that acetabulum, and it's going to take a massive force to get it out. Okay. Okay. A lot of this is just repeats from lab. So in lab today, we're going to go over the ligaments of the knee, anterior posterior cruciates, medial and lateral collaterals, the patella attaching to, what is this bump on the tibia called? Tibial tuberosity. They call that the patellar ligament because it's technically bone to bone, but I still call it the patellar tendon because the quadriceps muscle comes all the way across and attaches. So they kind of separate and they call it a tendon up here and a ligament down here. Doesn't matter to me if you call that a ligament or a tendon. It's the same thing. If I'm doing a reflex test, okay, a tendon attaches muscle to bone, right? If this is a ligament attaches what? Bone to bone. If I did a reflex test on a ligament, would I get a response? No, because it's bone to bone. It's got to be muscle to bone in order for me to get a, so, no, I beg to differ with the anatomy docs, but that's just because of my experience with this. Okay, menisci. So we'll look at those two. You guys already know that's fibrocartilage. The lateral meniscus tends to be a little bit larger than the medial meniscus, but the one that's going to break down the most is medial, because your medial condyle of the femur, if you guys notice when you go in lab, sits just slightly lower than the lateral condyle. So you get more weight bearing on the medial aspect of the knee than you do lateral, so it wears out first. What else? So again, menisci are for shock absorption, and then the ligaments are going to be for structural integrity. Common knee injury is called the unhappy triad, and that's where you get a lateral blow to the knee, and that's very common in football. That's why all you guys that watch pro in college, most of those football players are wearing knee braces, because there was a period of time where these guys were just going down like flies and they were out for the season because they all had blown ligaments. And so the coaches decided, screw this, we're going to throw some braces on you and prevent that from happening. So if you get, like, somebody tackles you on the outside of your knee, you're going to tear your ACL, you're going to tear your medial collateral ligament or tibial collateral ligament, and you're going to tear your medial meniscus. So that's why they call it an unhappy triad, and you are out for the season. Out for the season. Okay, so very, very common injury. And more common in high school, because high school is just getting insane in terms of sports. There's going to be a lot of arthritic people in the future, just because of the demands in your youth from sports. Let's see, as far as this goes, nothing major. TMJ stands for temporomandibular joint. So that's the head of the mandible articulating in the mandibular fossa. Okay, has anyone had TMJ here? Yeah. So I didn't think really TMJ existed until I got it myself. This was in PT school. I went to a conference with some friends and we shared a hotel room. And it was just the first night. In the morning, got up, and my classmate said, Brenda, you know, we think you grind your teeth because we heard you like grinding in the night. And I'm like, really? I'm like, yeah, I can grind your teeth. So I was like, okay. So I went to the dentist, and he's like, yeah, you know, I do see some wearing of your, you know, enamel. So he prescribed a bite guard, which I still use. I've been using it for years and years and years. Of course, stress related. I'm in PT school, kind of stressful. So that's what caused it. But that's just grinding. So before I got the bite plate, I woke up one day and I was gonna brush my teeth. And I couldn't open my mouth all the way. Like one side, I can't remember which side it was, gave me this tremendous pain. And it really like limited my ability to open my mouth. I was like, what the hell is going on? Of course, this is a weekend. The dentist isn't open. It's not an emergency. So, okay, fine, I'll wait until Monday. But in the meantime, I had like, I think I went out for sushi with some friends. And it was so embarrassing because I couldn't even like open my mouth to put a roll in. I had to anatomically break down the roll and like shove it in my mouth. It was awful. I'm like, this sucks. It was like torture. I'm like, this sucks. So, anyways, Sunday night, my parents, my dad, thank God, decided to make pizza. And great, okay. So I shoveled a piece of pizza in my mouth. I took a bite. I felt the click, and boom, I had motion. I was like, oh my God, what happened? Oh, I was screaming, like so happy. So what had happened was I had subluxed or partially dislocated one of the joints. And that was probably because I was grinding. And then when I bit into the pizza, it like gave the joint enough traction where the disc just slipped right back in, and then I had normal motion. It was amazing. I'll never forget it. That's why I tell the story. So TMJ does exist. I've had it before. It's quite annoying and can be very debilitating for people that have it chronically. Fortunately, mine was a one-time thing. Okay. So, sprains. Sprains versus strains, because you'll hear both. Okay, sprains are ligamentous. Strain is muscle. Okay, so if you hear someone has a quadriceps strain, okay, they probably partially tore their quadriceps. If someone has an ankle sprain, then they probably irritated some ligaments around the joint and or stretched them, whatever. The ligaments are involved. Dislocation means like ball and socket disconnected. Subluxation, so sub with the luxation means a partial dislocation. Maybe it partially happened. So some people can get a subluxation of the shoulder and then be able to pop it right back in place. These are people that have chronically subluxed their shoulder and they know how to pop it back in. Problem with that is that you get wear and tear of the joint every time you do that. It's super traumatic to the joint. So those people should be strengthening with a physical therapist, not just constantly popping the joint back in and going back to whatever sport they're playing. But I've said my piece. Tendons, bursa, can get inflamed, itis, okay? Excessive synovium, you can get swelling. Achilles tendonitis in your Achilles tendon, the back of your calf, overuse. Okay, you can get biceps tendonitis from too much trying to help out the rotator cuff because you have a rotator cuff tear, for example. Okay, and then the only other thing I want to talk about with arthritis is osteoarthritis versus rheumatoid. Okay, gout has to do with excessive calcium crystals that usually like houses itself in the big toe of people. It can be quite uncomfortable. But you don't have to memorize that. Artificial joints, again, I work with those all the time. But the two kinds of arthritis that you're probably most commonly going to run into, if not get it yourself over time, is osteoarthritis versus rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disease. So that is where your own body starts to attack itself. So autoimmune. Okay. Osteoarthritis is just wear and tear, degenerative changes over time. Okay, so the construction workers, the heavy labor workers that come in to see me with osteoarthritis of the knees, okay? So this is showing you where we've got bone on bone here. So the articular cartilages, which are nice and healthy in a normal joint, have now been eroded and they're now compressing each other and there's no break. So there's a reduction in synovial fluid, okay? And it causes pain. It causes bone spurs, it causes excess bone from all the rubbing. All that rubbing creates friction and your body starts to lay down other little pieces of bone. Bone spurs, those are very painful. Rheumatoid arthritis is where your synovium becomes like pickled. It's not the right ingredients. So you've got some bad ingredients in your synovial fluid, and that starts to erode your bones. So it starts to break down bones, okay, bony erosion. That causes inflammation, that causes pain. Rheumatoid arthritis usually happens in like the feet and the hands. People that have rheumatoid arthritis, oh, just looks so painful in the hand, just swollen. Okay, if I had to choose between the two, I personally would rather have osteoarthritis because the wear and tear takes years and years and years. To the point where after a while you might say, you know what, that total knee replacement sounds really good, you know? Or, you know, I think I'm gonna do that total hip because, yeah, this is like 10 out of 10 pain. You know, people who have had arthritic pain, they know pain. I mean, they're dousing like 5 leaves and their poor livers, you know, are just like, stop. So after a while, you know, if you're looking at that staircase going, oh my God, where's my medication? Like, it's probably time to do something. Like, and total joints are amazing. Half the time it's trying to convince the patient to do it because they're like, oh, it looks like it hurts so bad. I'm like, the pain that you're in right now is nothing compared to total joint. You'll feel the incision, you'll feel a little pain from the actual procedure, but that's nothing compared to bone on bone, ratcheting pain with swelling. It's not the same, you know? And once they kind of sit back and just kind of let that percolate a little bit, and they talk with the doctors, the problem is that the surgeons have no personality. They're just there to cut, you know, so they're just like, and then, you know, patients are just like, oh my God, and then they get on the internet and they look at everything, it's like, oh my God, don't look on the internet without talking to someone who can like walk you through it, because then they freak out. And I say, don't, you know, these guys are experts and they do total knees like every day. So if you can convince them and they get it done, 99.9% of patients come back and say, thank you God, I'm so glad I did it. I told you. You know, I don't even have arthritis and I just can tell the difference. Okay, I think that's the last. I'm done talking. Questions?